we started speaking about how to make visible the invisible, and I think that we are concluding this journey really to try to see how we can visualize at the moment what it is the inflammation psoriatic arthritis. These are my disclosure. We have heard that the most important unmet needs in the challenges that we face every day in psoriatic arthritis, and I will speak now about psoriatic arthritis, is the delay in diagnosis that is so important as it is important in axial spondyloarthritis. And we know also that by different study, clinical study, ultrasound study, that the structural progression, the peripheral structural progression is linked to synovitis and enthesitis. And we want always to know when we have patients with psoriatic arthritis that can be characterized by different phenotypes, what is the prediction of response to a treatment. I would just show you this picture that I love to show because I think that ultrasound is the technique for evaluating at the moment what happens in the peripheral joints, inside the joints, outside the joints, in patients with psoriatic arthritis. I think that using power Doppler, so the color, the visibility, we can really visualize what happens in our patients. And another thing that I would like to say that you have seen how beautiful are the pictures, but one of the main comments that we receive as ultrasonographer is you are not reliable, you are not standardized, is an operator-dependent techniques. And what we show that we have developed over the last year, believing in this technique, a reliable ultrasound scoring system that is able to visualize the synovial hypertrophy, so the morphological abnormalities that we squeeze with our joints, and the presence of an inflammation of within this tissue, which is the power Doppler, which is the vascularization, that may, I would say, correspond to other serological marker of disease activity. Putting together these two components, we can really cover the inflammation of all the joints in psoriatic arthritis. We have also tried and obtained to make visible what it is the enthesitis. Already Georg told us how it's difficult to visualize the pain in the joints that they are not swollen. And we always believe by clinical practice that it is an enthesitis. Using ultrasound, we can visualize what it is happening in the enthesi, where is the inflammation, where is the structural damage, and what is the pain, the cause of the pain. And in that case, with Inomeract, we have also graded the presence of an enthesitis at site level in a way in which we can consider the B mode, the edema of the enthesis, and the Doppler, the presence of a vascularization that is so difficult sometimes to detect. So, from psoriasis to psoriatic arthritis, how we can use ultrasound? Several studies have shown that in patients with psoriasis, even without pain, it is possible to see abnormalities in the joints, in the synovial membrane, but also in the enthesis. But it is even more important to visualize this inflammation when there is pain, to discriminate if the pain is an inflammatory pain linked to a subclinical disease, telling the disease is probably already there, from another pain that can be linked to eventually structural damage. And believing so much in this technique, we perform a study that it is a really important study. It's the first study that used ultrasound, and especially the ultrasound-detected synovitis, as a primary endpoint. We really wanted to see if we were able to visualize the inflammation and to evaluate the inflammation in an objective way in patients with psoriasis. For this reason, we perform worldwide a randomized control trial, placebo control, we use secukinumab, 150 or 300 milligrams, according to the skin extents of psoriasis, in patients that were not incomplete, that were not responders, but had active psoriatic arthritis based on swollen joints and no response to conventional DMARDs or NSAIDs, and with at least one clinical enthesitis. We examined them by ultrasound, and patients with synovitis activity by ultrasound were randomized in the two groups. So our primary endpoint was the response on synovitis at 12 weeks. Then from 12 weeks to 24, we switched the placebo to secukinumab, and then we followed them until 1 year. We also had other questions to this study, not only the response at the synovitis level, but also to confirm the study and the data that we know on the efficacy on secukinumab in psoriatic arthritis, but most importantly, to explore the possibility to use ultrasound for following enthesitis. So, you can see here the baseline characteristics of the clinical joints involved and in these patients. You can see that there were patients with a disease that has almost 6 years of disease durations. There were the classical psoriatic arthritis that you include in your study, and you see that the gloss, which is the sum of the synovitis at the joint level, was quite high, and you can also see the amount of synovial hypertrophy in B mode and the amount of Doppler signal. They were clinically active in the enthesitis based on the SPARC, and you can see that the mean number of entheses was almost the same between clinical evaluation and ultrasound. But since we didn't use ultrasound as an inclusion criteria for enthesitis, you see that not all patients had an ultrasound-detected enthesitis. And so we were using B mode and Doppler at definition to try to capture the inflammation on enthesitis, or to see if we could use only the Doppler signal as a measure of inflammation. If you can see by this graph, probably we didn't have so many patients with a Doppler activity in enthesitis. If you look at the distribution of synovitis, according to the way in which we can measure synovitis, so swollen joint, tender joints, and by ultrasound, you can see that most of the patients had the wrist as the main joint involved, the knees, the MCPs, and the MTPs. And what it is quite normal, because this is the usual population that we include in this study. If you look at the distribution of the enthesitis, the ultrasound-detected enthesitis, also these show us that the elbow, the knees, and the Achilles tendon were the entheses more frequently detected, either by clinical evaluation, but also by ultrasound, telling that the elbow is something that we have to look for. You can see here our primary response. The primary endpoint was met, and we were able to demonstrate objectively the response to secukinumab, the differentiation between placebo and secukinumab starting from the first week. And you see nicely that ultrasound decreased over the time until the 12 week. And if you look at the second part of the study, so when the placebo was switched to secukinumab and over all time, we can see nicely how ultrasound is able to show the response very nicely also in the placebo, and we can follow these patients over time with ultrasound, showing that the disease was controlled. What about the enthesitis? You can see here that although it was not one of the primary criteria, nor the secondary criteria, we demonstrated a nicely differentiation between placebo and active drug in the first 2 weeks, probably not at 12 weeks, but when we switched the patients from placebo to secukinumab, also the OMERACT ultrasound enthesitis was able to show this response that was nicely seen until the end. What about ultrasound to predict the response? So we in order to try to see if we were able to identify the patients who would have respond better to secukinumab, we perform a cluster analysis on the baseline data based on the ultrasound characteristics of synovitis in these patients. What we seen is that we were able, based on the ultrasound characteristics, to identify 3 groups of patients. Cluster 1 that were mostly characterized by enthesitis, synovitis, and quite well distributed, like cluster 3. But if you look at cluster 2, was the cluster in which we detected the lower number of inflammation by ultrasound. And if you look at the response based on the cluster analysis, you can see that overall, in the first 12 weeks, we can see very well the differentiation between the placebo and control. But if you look at the cluster, you see that cluster 1, that it was characterized by big joints and small joints, demonstrated a very nice differentiation between placebo and control. Also, the cluster 3, that it was more characterized by small joints involved. And if you look at the cluster 2, that it was the cluster in which we found less inflammation by ultrasound, this was the cluster that we were not able to differentiate between placebo and control. In conclusion, what these studies tell us, that synovitis and enthesitis are a true marker of disease activity, and they are critical for cartilage bone destruction in PsA, because study demonstrated that if you do not control the disease at this level, you will have structural damage. Power Doppler ultrasound is an objective and easy tool to evaluate synovitis and enthesitis response, and we were able to demonstrate that secukinumab was really rapid and effective, starting from the first week, to demonstrate the response to the treatment, supporting the use of this drug in the pathogenesis in the pathway of synovitis in PsA, and the use of ultrasound for monitoring this. Thank you very much.